Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to be discussing first rib dysfunction. We're going to talk about how you assess for it, and then also how you treat it in session, and then also what do you do about giving exercises for patients to help reinforce the gains that they've made in session. We'll get that at the very end of this video. So first of all, first rib dysfunction is usually a hypomobility, a stuck sometimes called, really just a stiff first rib. It's a very common impairment, and I guarantee you that there's patients who don't even come in with a related issue to that. Maybe it's low back pain, it could be knee pain, it could be people working in your clinic. It could be symptomatic or asymptomatic, but there's probably individuals who have some degree of stiffness in one or both first ribs. It's extremely common. It just may not always cause symptoms. But what are some common things you might see in the clinic that would lead you to at least test for hypomobility of the first rib? So first of all, pain with neck motion. Of the neck pain classification system, the one I've seen most commonly where this is the case is neck pain with mobility deficits. So again, neck is stiff, maybe it's muscles, maybe it's arthritis, but one thing that is often overlooked is stiffness of the first rib. Also, numbness and tingling into the upper extremities. Sometimes that could be a radiculopathy, but if you suspect thoracic outlet syndrome, you should definitely test for first rib hypomobility. Remember that the space between the first rib and the clavicle, so the costoclavicular space, that is one of the three primary sites where structures get compressed in thoracic outlet syndrome. And many times it's a combination of any of those three areas, including under the first rib. And then also, anytime there's isolated pain near the first rib, okay? And remember, the first rib starts at the T1 vertebrae, and it goes out laterally and eventually kind of goes posterior to the clavicle and sort of crosses under it more laterally, okay? So it's kind of right above and a little bit anterior to that supraspinatus, or I should say suprascapular space. Now, how do you determine if a first rib is hypomobile? Well, you test its mobility, and there's really two ways to do that. The second method, which we'll look at in just a minute, is an indirect method because you're not actually touching the first rib, but it's known as the cervical rotation lateral flexion test. That's my preferred method. It's usually a lot easier for patients to tolerate. The direct method is where you're actually contacting the first rib, and that is the seated or supine rib 1 springing, or just spring testing of the first rib. We're not going to go over that test in this video because we do that in other videos on my channel, but essentially what you're doing is you're putting direct pressure on that first rib and seeing how it moves. Now the pros of that is that it's a direct measure or feel for the mobility of that first rib, okay? You do this enough times and you'll be able to determine a normal rib from a slightly limited to very limited, just immobile or stuck first rib. The problem with this technique is that a lot of individuals, especially those with kind of that thoracic outlet syndrome or neck pain with mobility deficit presentation, they have rock hard upper traps and muscles in that area that you're going to have to push through to get to the first rib. And for most people, it's not that pleasant. You'll get some people who have a decent pain tolerance and they'll take it, fair. But for a lot of people, it's not pleasant. So that's the main con of this. And when we get to treatments in just a little bit, again, I won't show you the direct mobilizations or direct manipulations. We do that in other videos. But the pros and cons of those are the same thing. You're putting pressure directly on the rib, which if they can tolerate it, that's a pro. But if they can't, it's obviously a con. The mobility of the first rib can also be assessed with what's called the cervical rotation lateral flexion test, or the CRLF test. Don't say that too fast. Understand that this test can also be positive for hypomobility of the cervicothoracic junction. We'll get to that in just a little bit. This is also not to be confused with the cervical flexion rotation test, which we covered previously. That's for use with assessing the mobility of the atlantoaxial joint up in the upper cervical spine. Okay, so let's get to this test right now. The patient will be positioned and seated, as you see right here, and the PT is going to passively rotate the patient's neck away from the test side. Okay, so let's see which side I do first. So I'm rotating her neck left. Okay, that means I'm assessing her right first rib. And then from here, once I rotate maximally, I'm going to try to bend her ear here down towards her sternum. So you have the rotation, there's the lateral flexion. And I'm looking for two things. One, any subjective reports of pain or anything strange like that, but also the degree of motion, because I'm going to compare it to the other side. Okay? So now I'm going to be testing the mobility of the left first rib. There's right rotation, and then here's the lateral flexion, or the side bending. And I'm looking for, again, pain or any side-to-side differences. Also note that if you have a really, what they call a stuck first rib or a really hypomobile first rib, you may encounter a hard end feel. Okay? This should not be a hard end feel. If you have that, it is definitely a positive test, and it could be like that on one or both sides. Also note that if it's truly a first rib issue and there's pain, the pain is going to be felt just posterior to the clavicle. Okay, so kind of right in that suprascapular space, you'd have to push in there. That's where the first rib is. If the pain is associated with the CT junction, they're going to feel it right on the spine in the CT junction. So the location of that pain can help you differentiate what's actually the problem. Okay, so first of all, we've kind of already hinted at this. What constitutes a positive test here? Well, obviously reproduction of pain. You need to ask where that pain is. If the pain is at the CT junction, then that's going to take us to a completely different type of mobilization or manipulation, and we'll cover that in other videos at a later time. But if it's in the area of the first rib, then that tells us, well, we may need to mobilize the first rib. And then, of course, if there's any obvious asymmetry. And usually the asymmetry is going to be noted on the lateral flexion. Okay, so for example, look here. So we've got rotation there, and we've got the side bending. Let's say this is the negative side. This is normal mobility. She has no issues with her right first rib. But then let's say we keep going, we test the left side, so we get the rotation, and I start side bending, and that's all she's got right there. Let's say that's all it went. Well, then that would be an obvious asymmetry, and that would tell us, especially if there's pain in that area, we might need to try mobilizing that left first rib. That then leads us to the actual mobilizations, the treatments, of which there's three main ones that are used in the clinic. The first two options are the ones I learned in PT school. The third one I learned later on in a continuing ed course. But these first two options involve actual manual contact on the first rib. And the first one is direct Maitland mobilizations, the same graded mobilizations that you've seen throughout all your physical therapy training and in practice. Grades 1 and 2 are going to be used for painful restrictions to reduce pain. Grades 3 and 4 are for non-painful restrictions for improving range of motion. And this can be done in the supine position, as you see right here. It can be done in the sitting position, as you see right there. Now, the Maitland mobilizations work pretty well for slight limitations. But when you get very limited first ribs, or what I would call immobile, like they just don't want to move, it's like a hard end feel, it's going to be more challenging on those, especially because you got to be down there for like 30 seconds to a minute for the full set of a mobilization. And sometimes you got to do that 3 or 4 times. Okay, and that can be especially problematic if the patient's got these rock hard upper traps, like upper traps where it looks like they've been doing shrugs with 300 pounds in each arm for years, like tight rocks. You got to dig through all those upper traps, and a lot of people aren't going to have the pain tolerance to be able to handle that for 30 to 60 seconds, let alone multiple sets of that. So that's where this one comes to a problem. Okay, if it's slightly limited and you don't have much here to dig through, it's probably going to be okay. If you've got a lot of upper trap tightness, and especially if it's painful, you're probably going to go with option 3, which we'll get to in just a minute. But option 2 is the thrust manipulation. Again, it can be done in the exact same positions, supine or sitting, pretty much exactly how it's shown in these pictures. I would make an argument that the thrust manipulation is better when it's very limited or immobile than the regular mobilization is, just because in a manipulation, you get in there through the soft tissue, you do a quick thrust, and you're out. Whereas for the actual mobilization, you got to be down there for a longer period of time. However, it can still be a problem if it's really limited. You might have to do it a few times, and especially if they've got all that upper trap tightness, tenderness, you're probably best off going with option 3. And then that leads us to option 3, which is an MET or muscle energy technique or a PNF technique. Technically, there's differences between those. We really don't care. This one works amazing, and it's useful for a number of reasons. One, It's because it relies on a positive CRLF test, meaning the test is really easy to do. The test and retest, that is, and you don't have to dig in there even for the test like you would if you were doing a spring test on the first rib. And then this is a much, much gentler technique, and clinically speaking, you get pretty amazing results really fast in the clinic. So what do? The PT places their distal brachium on the patient's first rib area, and understand that you're not actually having to push in, you're just resting it there. And then they place the volar aspect of their forearm on the side of the patient's head. So here we're going to assume a right first rib hypomobility. So the right first rib was hypomobile. So a positive right CRLF test. Okay, let's take a look at that. So I'm going to put my brachium, distal brachium, on her first rib area. I'm not pushing down. I don't have to push down. Okay, and then my volar forearm is against the side of her head. Okay. The patient is then instructed to side bend with approximately 10 to 20% of her maximal volitional contraction force into my forearm. So she's going to be side bending her head towards her right. This is held for 6 seconds, okay? So she's going to push in. You'll see that in just a minute. And any day now, there it is. 1, 2, 3, 4, 5, 6, and relax. We take a little pause there, and I usually repeat this anywhere from 6 to 10 repetitions, always holding about 6 seconds. You would be amazed how fast you can affect somebody's pain here and get better mobility just by doing this. I'll always, again, retest with that CRLF test to see if we made any progress with this. But again, it's quite amazing how just 6 to 10 repetitions of this can improve pain and mobility so much. Bottom line, always use that test, treat, retest model. Let's take a look at it one more time. Go again. 1, 2, 3, 4, 5, 6, and so on and so forth. Now, let's suppose that you went through all this testing, you did this mobilization in session. You need to give the patient a home exercise program to reinforce what you found and what you did in session. So if I ever have a situation like this, I usually give a patient 2 exercises. One is just a simple Therex, and that's the first one here. And the second is more of a neuromuscular re-education type of technique. So the first one is just cervical rotation plus contralateral side bending. This is really just a combined active range of motion exercise. So for the sake of this argument here, let's suppose my left first rib was what was stiff. Left side is stiff. How did I test the left side with that CRLF test? Well, I passively moved the patient's head away and side bend it like this. So it would stand to reason if I want to maintain that range of motion, one of the things I can do is have the patient just do that movement through active range of motion. So it'll look like this. If it's a left-sided stiffness, I'll rotate away, side bend ear to sternum, come back. I can even throw a little hold in there as long as it's not painful. Maybe hold there a couple seconds, come back up. And I just have them repeat this active range of motion, maybe 10 to 15 repetitions, okay? If I had the right side stiff, I'd go the opposite way. Rotate away, come down, come back. So that is a very easy exercise for a patient to do. You just need to make sure that they're doing the movement in the correct direction. One of the more effective ones that I've seen is actually the strap-assisted rib 1 self-mobilization. So let's go back to left side here is stiff. You're going to need a strap, and we're going to put this strap right over where that first rib would be, assuming I was doing the rib springing. So you need to educate the patient on that position there. One part of the strap goes on around the front of my chest, the other wraps around my back, and I can grab it here as it comes around the other side of my back. And I'm going to apply a pressure down with both sides so that this is compressing down where the first rib is. Now we know that when we inhale, all the ribs come up. So we're going to use this downward pressure against an inhalation force to indirectly mobilize that first rib. And I like to do this with diaphragmatic pursed lip breathing. So from here, one repetition will look like this. I'm going to inhale through the nose and then exhale through pursed lips. And while I'm exhaling, I'm also continuing to pull down here. So I'm going with the exhalation. Let's do that again. Inhale through the nose. Maintain that pressure. Exhale and pull down further. And that is a really good self-mobilization, more of a neuromuscular re-education of that first rib that you can combine with that first exercise as part of their home exercise program. So hopefully this video gave you a good understanding of how to assess the first rib, how to treat it in session, and also give exercises to reinforce said treatment. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.